Good evening, this is Pei Chang, and today I'm presenting an implementation measurement appraisal for the Implementation Leadership Scale, or ILS. We will use ILS as the abbreviation moving forward. In the fast-paced and stressful environment of the ICU where I work, launching an AI system to spot sepsis early is more than just a technical problem. As this evolves, human participation and the process needs to be adaptive too. We are using ILS as the tool to see if hospital leaders are truly helping staff follow this newly introduced system, or if their leadership style is actually making it harder for doctors and nurses to do their jobs. A sepsis early warning system is essentially an intelligent smoke detector for patients' clinical course. Sepsis is a life-threatening emergency that happens when the body has an extreme response to an infection. And every hour of delay in treatment significantly increases the risk for death. This system works by constantly scanning a patient's digital medical records, including to monitor things like heart rate, blood pressure, and lab results, to find hidden patterns that suggest sepsis is incoming. By catching this tiny red flags early, the system can instantly alert doctors and nurses, allowing them to start life-saving treatments like antibiotics or fluids hours before patient actually decompensates. Let me briefly explain what ILS is and why it matters for our ICU. The ILS is a short 12-question tool that measures how well leaders support the rollout of a new evidence-based practices. It looks at 4 simple areas. Number 1, proactive leadership, where the leaders take initiative. Number 2, knowledgeable leadership, whether they understand the new practice. Number 3, supportive leadership, whether they encourage and guide staff. Number 4, perseverant leadership, whether they stay committed when challenges come up. In our ICU, we can use the ILS to see how leadership is influencing the adoption of this new sepsis early warning system. Strong leadership behaviors make it more likely that clinicians will follow new protocols consistently. On the other hand, if the ILS shows gaps like limited support or unclear guidance, we know exactly where to focus improvement efforts. Overall, I think the ILS helps us understand whether leadership is truly setting the stage for successful implementation. Now let's look at how this tool is used. The ILS is a staff-reported assessment. That simply means it's filled out by the people who work on the unit every day: nurses, respiratory therapists, and even the resident physicians. They use it to rate the leadership behaviors they see from their direct supervisors, like me. So what does it measure? It looks at whether leaders are creating the kind of environment where new practice can actually succeed. This matters because even the best tools, like this AI-driven sepsis alerts, will not be effective if staff do not feel supported or guided by our leadership. Without visible, knowledgeable support, the buy-in drops quickly. The scale was originally developed in mental health and social service settings, but it is now used widely across healthcare, especially in acute care settings, like in our ICU, where the stakes are high and leadership has a big influence on how the daily workflow would run. Overall, again, the ILS helps us understand whether the leadership climate is truly ready to support new systems like our warning system. Here's how I plan to interpret and use the ILS. I think of the ILS as a diagnostic tool, something that helps us check the overall health of our work health environment before and during the rollout of an AI-driven triage system. By looking at 4 areas, the ones I mentioned before: the proactive, knowledgeable, supportive, perseverant leadership, we can spot specific leadership gaps that might lead to low buy-in or staff fatigue. Once we know where those gaps are, we can tailor training for unit leaders so their behaviors help. rather than slow down the adoption of this new technology. As for who fills it out, the whole ICU team will participate. Just as I mentioned earlier, physicians, nurses, and administrative triage staff as well. They see leadership up close every day, so their feedback is essential. We will also use the tool over time. First, we will collect a baseline 3 months before launch to make sure leadership is ready. Then we will check again 6 months after launch to see whether support is holding steady or start to fade. After that, we'll use the IOS once a year as part of a routine check to make sure leadership continues to create a strong environment for ongoing innovation. This overall is considered as the adaptive process I mentioned earlier. And this IOS helps us make sure leadership is truly paving the way for successful implementation moving forward. Let's take a quick look at how strong the iOS is as a measurement tool. The good news is that the iOS has been comprehensively tested and studied. When it was first developed, researchers confirmed that it measures what it's supposed to measure. The 4 areas, as we mentioned earlier again, it looks at proactive, knowledgeable, supportive, perseverant leadership, really to capture what strong implementation leadership looks like. It's also a very reliable tool. When different staff members rate the same leader, their scores tend to line up, and the questions within each category work well together. This tells us the scale is consistent and trustworthy. Another helpful feature is that iOS can pick up changes over time. For example, if leaders go through a training program, the scale is sensitive enough to show improvement afterwards. The only limitation is that we do not yet have a standard cutoff for what counts as a meaningful amount of change across all clinical settings. To sum up, this iOS is a solid, scientifically supported tool that gives us dependable information about leadership behaviors that matter for successful implementation. Before we rely on the iOS, it's also important to understand its limitations. First, even though iOS is short, getting people to fill it out can still be difficult in a busy ICU. Night shift staff and clinicians who are constantly on the move may not have the time or energy to complete the surveys, which can lower our response rates. Second, this tool is based on staff opinions, which means the results are pretty subjective. Some people may rate their leaders more positively than they actually feel because they're worried about anonymity or possible consequence. This kind of social desirability bias can make the results look better than reality. Third, the results can be shaped by the culture of each unit. Every ICU has its own way of communicating its own leadership style. So even though the iOS has been validated in acute care settings, scores from one unit do not always apply to another. While it looks like strong leadership in one environment, might not look the same somewhere else. This concludes my short presentation for iOS as my appraisal project. Here are the references. Unfortunately, I'm not able to participate in the live class session due to my conflict of my clinical schedule. If you have any questions, feel free to email me or WhatsApp me on the number I provide here. Thank you for your time and attention.